Hi, it's Dr. Centeno, and I'm actually broadcasting today from a medical conference. I found a little room. They may kick me out of this room. I don't know. Medical conference is in a slightly different part of this hotel convention center complex. But I wanted to try to get this video out today just because I think there's some critical information. I only have about 30 minutes today to do this, so I don't have the traditional hour. So I'll certainly get into the topic and then answer questions to the extent I can over the next half hour or so. So again, at a medical conference, cordoned myself off into a little meeting room here. They may kick me out. I don't know. But in the meantime, today's topic is an important one, and that is we're seeing more and more patients come in for orthobiologics that are on corticosteroid medications. Sometimes that's to support things like adrenal fatigue. Sometimes they're taking that for their POTS. And those medications are contraindicated for orthobiologics. So we're going to go into that. Again, as usual, we'll start with a short presentation, and then from there, I'll take questions. Again, just for those of you that are just joining us now, I'm at a medical conference, have found a little room here I think is safe to use, but they may kick me out. I only have about a half hour today, just because, I'm part of this medical conference, lecturing, etc. So let me start with the presentation, and let me go ahead and share my screen here. I'm also on their Wi-Fi, so I can't really tell you that this is going to work out great, but I'm giving it a shot all the same. So let's see here. Let's share the screen, and then we'll start the presentation. And there. Okay, so the presentation today is going to be why taking oral steroids for POTS or adrenal fatigue could adversely impact the PICL procedure, or really any orthobiologic procedure, not just PICL. So what is a corticosteroid? It's an anti-inflammatory prescription drug that is commonly used throughout medicine. Common drug names for oral meds, fludrocortisone, prednisone, betamethasone, dexamethasone, hydrocortisone, methylprednisolone, cortisone, triamcinolone, celestone, and prednisone. So as you can see there, these medications pretty much all end in that ONE. So if you're taking a drug that ends in ONE, that could potentially be a problem. In the CCI population, these drugs are commonly prescribed for things like POTS and adrenal fatigue. And we've seen more and more patients come in on them. Many times we'll catch these, or the patients themselves will catch these after reading our information. But every once in a while, a patient slips through the cracks and still makes it to our office on one of these drugs. And you don't want to be that patient because it may adversely impact the outcome from your procedure. And that's because the PICL procedure and many other orthobiologic procedure uses the patient's own mesenchymal stem cells in bone marrow to help with ligament healing or healing other tissues. So anything that adversely impacts those mesenchymal stem cells could be a potential problem. And we know that corticosteroids do adversely impact the function of bone marrow mesenchymal stem cells. In fact, that's so severe that if you're on these drugs for any length of time, your risk of getting a serious bone disease called osteonecrosis, where your bones turn to mush, goes dramatically up in a dose and time-dependent fashion. And that's because the bone marrow mesenchymal stem cells get adversely impacted. The bone can't repair itself. It starts to die off. Again, as I talked about, simply taking any one of these drugs increases the risk of getting osteonecrosis by 20x or more. So just realize that there are other reasons not to take them, not only that they could affect an orthobiologics procedure. You need to be off of these for at least 6 to 12 weeks. So you should be off of oral corticosteroids before your PICL procedure for that long. So we'll go to questions, but this is an important message I wanted to get out today, and we'll see what kind of questions we got here. Again, I'm broadcasting from a medical conference today. Doesn't look like we have any questions, so this could be real easy for me. So again, broadcasting from a medical conference today. I don't have the full hour. I've got 30 minutes. If there's anyone with questions out there, happy to answer those questions. I'll give you a few minutes here to get some questions, but I did want to get this important message out. So again, if you're on a corticosteroid pill, that can affect the outcome of your PICL or other orthobiologic procedure. And best thing to do is obviously get off of those drugs. Happy to talk to anyone about that. So here's a question. Kimmy, when measuring for basilar invagination, do you use the Chamberlain line or McRae's line? Is it possible to have a slight craniosettling and still be helped by PICL? Yeah, there isn't really a problem with slight cranial settling, meaning slight cranial settling in general doesn't cause symptoms in most patients. We use, just to make it very simple for people rather than the jargon, we use the line that goes across the bottom hole of the skull. And we do not use the line that comes back from the palate. So bottom line is, we have to see the dens encroaching on that line across the bottom of the skull before we'll even call that diagnosis of cranial settling and basilar invagination. Kimmy, going back to gaze problems and vertigo dizziness, is this something we should work on with VRT? Can the vestibular ocular reflex be fixed regardless of what is going on in the neck, or does the neck need to be fixed first? Certainly trying either vestibular therapy or vision therapy is a great thing to try conservatively. If that's not working, in general, the neck needs to be fixed first. Lisa, I was just prescribed dexamethasone for COVID for a week or 10 days, I think it is. Is that still risky for an EDS patient and CCI patient? A week or 10 days is unlikely to cause problems. It's really when these drugs are taken at dose for months. Now, how high is your risk for getting osteoporosis for taking something for a week? Not high. It's maybe doubled or tripled, but it's extremely low risk to begin with. So double or triple of a small number is still a small number. Kimmy, you shared evidence for CCI chart on one of your most recent videos, and I was wondering if we could see that chart somewhere. The button of it was covered by somebody's question during the video, so we're unable to see the whole thing. I'll see if I can bring it up here. And again, sound effects from the background there. Can't control that because I'm in a hotel doing this down in the conference space here. So let me share my screen, and we will go to. I'll put that up again and see if we can maybe not have it covered by anything. Let me go and bring that up. So that's the slide here. Hopefully it's not as covered anymore. Maybe I can do it this way and make it so you can see it a little better. But that's the slide I think you were talking about. So screenshot that. And let me stop sharing now. We'll go back to some questions here. Kimmy, when measuring for basilar invagination, yeah, we got that one already. Sorry, that's my bad. I kind of skipped around there a little bit. Kimmy, you shared evidence for CCI. We just did that. Does the PICL address compression of the superior cervical sympathetic ganglion? I struggle with visual issues as well as being in constant fight or flight mode and dysautonomia. These are my main concerns, as I don't have a lot of pain that needs to be addressed. Yeah, I think compression is a wrong way to think about these things. It's more intermittent irritation due to instability. So to the extent that those nerves are being irritated, then the answer is yes, because the goal is to get rid of or reduce the instability so they're no longer being irritated. But compression is probably not an accurate way in most patients to conceptualize what's going on. Marcia had Centeno after my third PICL. I couldn't hold an adjustment, so we took new x-rays and the vectors have changed. Yeah, so that's pretty common, Marcia, after PICLs for the vectors to change. So it's a very good point. If you're in that situation where upper cervical chiropractic was working pretty well before to control your symptoms, then all of a sudden it stops controlling your symptoms, ask them to retake the x-rays and recalculate the vectors. Kimmy, I tick all the boxes on your likely due to CCI category from one of your latest videos, so I'm feeling fairly confident the PICL being a missing piece of my puzzle. I'm seeing you in March. Great, Kimmy. Happy to take a look, and obviously I'll let you know also based on the last part of that, which is physical exam. Any other questions out there? Like I said, I'm at a medical conference. I kind of stole away from lecturing here and found a cool little room in which to do this. But I may either get kicked out, and I can't guarantee that the Wi-Fi signal is all that great, but just trying to get this out there today. So any other questions I can answer for today? I'm happy to answer questions if you have them. Again, today we were talking about taking oral corticosteroids and how that impacts orthobiologics procedures in general. Procedure, the vectors changed because the CCA got more stable. In general, yes, that's generally what happens in that situation based on what we've seen in the past. So just to go over what we reviewed today, taking oral steroids can be a problem. If you're taking oral steroids for things like POTS or adrenal fatigue, that's something you have to stop before a procedure, and that's because they can be very hard on your body's own mesenchymal stem cell population. So obviously, if we're going to use those mesenchymal stem cells in something like bone marrow concentrate to try to heal ligaments or other structures, that's not going to be a net positive to be on those drugs. Okay, guys, it kind of worked out well today. I just wanted to get this out there, so I kept up the pace of getting information out there to patients, and obviously give people an opportunity to ask questions. I will be here this coming Friday. We'll do another video just like this. Looks like I got a few more in there. Edwin, I get that steroids hinder the healing of muscle ligaments longer term. Do you think the same is true for nerves? I was recently had a bout of vestibular neuritis, and the ENT prescribed me 2 weeks of prednisone to help reduce the dizziness, but if maximum healing long term can be achieved, I could easily just not take this since I'm not doing that bad. You know, if it were me, would I take high-dose oral corticosteroids? I might take them for a week or so, and 3 to 7 days. And if those have really helped symptoms, then great. But then I'd stop them after that if it were me. Obviously, you have to follow doctor's advice or choose not to. You know, one of the problems in the medical care system is that oral corticosteroids are kind of thrown around like M&Ms or holy water because they are powerful anti-inflammatories. The problem is they also have powerful side effects. So for me, if it were me personally, I would limit my oral corticosteroid exposure as much as possible. So if I took it for 3 or 4 days and I was feeling better, I'd probably stop. That's how I, as a physician, would look at those medications. Sure, Liza. Okay, guys, well, I'm going to sign off here. That was an easy one today. I got off light with fewer questions at a medical conference, so that's probably a good thing. I wanted to get a video out, wanted to answer questions. Thanks so much for watching, and you guys have a great day. Thank you.